Hello and welcome to my YouTube channel, AnatomyMentor. Today I will be discussing the development of the nervous system. This is the third and the last lecture in the series of lectures which were covering the embryology of the nervous system. And today we are going to be talking about the embryological processes that are involved in the differentiation of the diencephalon. And we should also discuss the processes involved in differentiation of the telencephalon. And I'll be talking about a few congenital anomalies associated with the maldevelopment of cerebrum at the end of this lecture. And also a few MCQs, which would be a recap of the previous discussion on neurodevelopment. So let's begin with the discussion on the forebrain. When we say forebrain, you know the medical term for that is the prosencephalon, and it in turn consists of an anterior part, which is the telencephalon, and that includes the cerebral hemispheres, the lamina terminalis. Whereas the posterior part of the forebrain, that is known as the diencephalon, and this includes different parts of the brain, which are optic cup and stalk, the thalamus, the hypothalamus, the epiphysis, also called the pineal gland, and the hypophysis, which is commonly known as the pituitary gland. Now, focusing on the diencephalon, you know it consists of a roof plate and two alar plates, but keep in mind it lacks the floor and the basal plates. The roof plate itself will form the choroid plexus of the third ventricle, whereas the most caudal part of the roof plate, that is going to give rise to the pineal body, also known as the epiphysis. Whereas the alar plates, they are going to form the lateral parts of the diencephalon. And the hypothalamic sulcus, it divides this portion into a dorsal thalamus and a ventral hypothalamus. So here are the diagrams which are showing the development of the brain. And this is a sketch which is showing the external view of the brain at the end of the fifth week. That is diagram A in the beginning. Right now we have moved forward. We have come to diagrams C, D, and E, which are now representing the later weeks. And E over here you can see is the transverse section, whereas C and D over here are the sagittal sections through the developing brain. And C is now representing the seventh week of development, and it is showing over here these cerebral hemispheres, which I told you they are derived from the part of forebrain which is known as the telencephalon. And then you've got over here the portions of the brain which are epithalamus, thalamus, and hypothalamus. These are the parts which are derived from the part of forebrain which is the diencephalon. And then comes the mesencephalon. Over here, let's look over here at the thalamus and the hypothalamus, and they are separated by the sulcus which is known as the hypothalamic sulcus. And in the upper, and you can see the caudal part is the pineal gland, also known as the epiphysis. And here is the region which is called the optic chiasma. This is also derived from the diencephalon. And here is the infundibulum, to which will be attached the pituitary gland. Then again, it is derived from the diencephalon. Now, E is the transverse section of the diencephalon. And here you can see in the wall of the third ventricle, you've got thalamus above and hypothalamus below. And on either side, you can see these parts of the brain are those parts which have, keep in mind, developed from the diencephalon. Now we're looking again at a sagittal section through this region of the diencephalon, and you can see that this area is the thalamus, this is the dorsal area, and the ventral area is the hypothalamus, and between these two parts, this here is the hypothalamic sulcus. And remember, they are developing from the alar plates. And in the roof of the diencephalon, caudally, we can see the pineal gland or the epiphysis. This is derived from the roof plate. Also, we can see over here the cerebral hemisphere and the midline lamina terminalis. These are the parts of the forebrain which were developed from the telencephalon. So let's discuss the development of the pituitary gland or hypophysis. Keep in mind it has two sources of origin, and these two embryological sources are derived from different germ layers. The first one is the one which is derived from the oral cavity. It is the outpocketing of the oral cavity, that is the stomodium, and it is ectodermal in origin. Whereas the second source of pituitary gland is the neuroectodermal source, which is actually the downward extension of the diencephalon, and this is the infundibulum. So here are the series of diagrams taken from Langman's medical embryology, and there this first one is the sagittal section through the cephalic part of a 6-week-old embryo, and over here in blue is the region which is the region of the developing brain, and here is more specifically the region of the diencephalon, and you can see the infundibulum. It is a downward extension of the diencephalon. Now remember, it is lined by neuroectoderm, and it is going to form a portion of the pituitary gland, whereas over here the area which is reddish or orange in color is representing the part of pituitary gland that is derived as an outpocketing or an extension of the primitive oral cavity, that is the stomodium. So this is going to be lined by ectoderm. These are the two embryological sources, the two different embryological sources of the pituitary gland. Now in the next diagram, you can see that these two tissues of origin, they have merged and they have formed this gland which is known as the pituitary gland or the hypophysis. And then there are subdivisions of the different parts of the hypophysis in the further weeks of development. As you can see in diagram C, which is the 16th week of development, it is showing over here that the posterior pituitary, that is the pars nervosa, and the adjoining parts of the infundibulum, they are derived from the diencephalon, that is, they are neuroectodermal in origin. Whereas the anterior lobe, and you can see over here the pars tuberalis and intermedia, these are the parts which are derived from the ectoderm, that is from the Rathke's pouch. Also keep in mind that the diencephalon is still going to be connected to the pituitary through this here median eminence and infundibulum, whereas the Rathke's pouch, it loses its connection. You can see it loses its connection from the oral cavity during the consequential phases of development. Now, this is a very good table which is actually summarizing the origin of the pituitary gland, because over here you can see they have separately mentioned the oral ectoderm and the neuroectoderm, and which part of the pituitary gland these tissues of origin are going to form. The oral ectoderm, as I showed you, is the hypophyseal diverticulum from the roof of the stomodium, and this is going to form the part of the pituitary which is known as the adenohypophysis. This is the glandular tissue, and it is subdivided into these three segments, namely pars anterior, pars tuberalis, and pars intermedia. We can also call this portion the anterior lobe of the pituitary. So these are the three parts which are the parts of adenohypophysis: pars anterior, pars tuberalis, and pars intermedia. When we talk about the neuroectoderm, it is neurohypophyseal diverticulum from the floor of the diencephalon, and the tissue over here is a nervous tissue, which is the neurohypophysis, and this includes the three parts which are the pars nervosa, infundibular stem, and median eminence. So this is the posterior lobe of the pituitary gland. In relation to the development of pituitary, you should know about the abnormality as well, that is the craniopharyngiomas. Occasionally, there might be persistence of a small part of the Rathke's pouch within the roof of the pharynx, and in that case, it is known as a pharyngeal hypophysis. Keep in mind the craniopharyngiomas are those abnormal tissue remnants of Rathke's pouch, and they might be present within the sella turcica or along the stalk of the pituitary, but they usually lie above the sella turcica, and they might cause pressure effects on the surrounding structures, leading to hydrocephalus and also the dysfunction of the pituitary gland, for example, diabetes insipidus or growth failure. Now let's come to the development of the telencephalon, which is the anterior part of the forebrain. As I mentioned before, this includes the cerebral hemispheres and the lamina terminalis. The cerebral hemispheres, they grow from the lateral walls of the forebrain and they expand in all directions until they cover the diencephalon, midbrain, and hindbrain. So we know it is the largest, massive, most prominent part of the brain, whereas the rostral part of the forebrain, the lamina terminalis, is very thin. So here we can see the expansion of the telencephalon forming the cerebral hemispheres, and this expansion is taking place in all directions. You can see posteriorly, anteriorly, and laterally. And in the midline would be this here thin sheet of tissue, which is the lamina terminalis. And here these are the developing cerebral hemispheres. Now, what is the corpus striatum? The corpus striatum appears in the 6th week of development as a swelling in the floor of each cerebral hemisphere, and it is further subdivided into two parts. That is, number one, the caudate nucleus, which is the dorsomedial portion, and number two, the lentiform nucleus, which is the ventrolateral portion. So here we can see that this is the coronal section through the cerebral hemispheres, and you can see this here is the caudate nucleus, and over here below that is the lentiform nucleus. So collectively this portion is known as the corpus striatum. So this is appearing in the floor of the cerebral hemispheres, and here in the midline you can see the section through the third ventricle, and in the wall of third ventricle on either side is the thalamus above and the hypothalamus below, separated by this here hypothalamic sulcus. Now the caudate nucleus, remember, is going to be elongated, and this is a C-shaped structure conforming to the outline of the lateral ventricle. So this is a three-dimensional image. In red you can see is the C-shaped caudate nucleus in the sagittal view, and if you look at it anteriorly, these here are the paired caudate nuclei, one within each cerebral hemisphere. Now, what is the insula and how does it develop? Due to the differential growth, the area between the frontal and temporal lobes of the cerebrum, that area becomes depressed and is known as the insula. Later, this becomes covered by an overgrowth of the adjacent lobes. Now, these gyri and sulci, which are the convolutions on the surface of the brain, they develop in the later half of the fetal life. And over here you can see these two diagrams which are showing the comparison in the earlier and the later half of the gestation. So in the earlier part of the intrauterine life, you can see the surface of the cerebral hemispheres is smooth. There are no sulci and gyri. And here are the subdivisions of the cerebral hemispheres: the frontal lobe anteriorly, and then the parietal lobe is behind it. Most posteriorly is the occipital lobe. And then over here on the medial aspect, you can see is the temporal lobe. But no sulci gyri have developed, and the insula is also still exposed. But in the later part of the fetal life, you can see now these grooves have appeared on the cerebral surface of the cerebral hemispheres. These grooves, which are known as the sulci, and so the elevations between these grooves, they are known as the gyri. You know that this increases the surface area of the cerebral hemisphere. Also, you can see that the insula has now been covered by the overgrowth from the adjacent lobes. So picture B is representing the 9th month of fetal life, whereas A is representing the 7 months of fetal life. So remember, it is the last 2 months of intrauterine life in which sulci and gyri are going to appear on the surface of cerebral hemispheres. Now, what are these cerebral commissures? These are bundles of nerve fibers which are going to connect corresponding areas of cerebral hemispheres with each other. And there are many commissures, but the largest and most prominent one is the corpus callosum. So this is a sagittal section through the developing brain, and the dotted line is representing the area of the future expansion of corpus callosum, right? But other commissures are also visible over here: the habenular commissure, the posterior commissure, and anteriorly you can see also you have the anterior commissure and the optic chiasma. Now, let's focus on the corpus callosum, which is the largest and most prominent commissure, which connects the right and left cerebral hemispheres. In the lateral view, this is the C-shaped commissure, or we can see over here is from the anterior view, you can see this is the bundle of nerve fibers, the corpus callosum, which is connecting the right and left halves of the cerebral hemispheres. Now we come to the birth defects of the brain. Now, the birth defects that are related to the development of the cerebrum, the first terminology that you should be familiar with is the encephalocele. Now, what is an encephalocele? It is the herniation of intracranial contents through a defect in the cranium, and the herniation of those contents is known as the encephalocele. Now, it might contain only the meningeal layer, then it is a meningocele, or it might contain, along with the meninges, the brain tissue, then it is called meningoencephalocele. Or if it also has fluid collection, then it is meningohydroencephalocele. Now that we're going to discuss the abnormality in the fluid collection, first we should discuss the normal pathway of the flow of cerebrospinal fluid. Well, we can see over here, this is a schematic flow chart which is representing the pathway of CSF flow. Where is CSF being produced? It is being produced in the choroid plexuses of the ventricles of the brain, namely the lateral ventricles, the third ventricle, and the fourth ventricle. So this is the site of production of the cerebrospinal fluid from the lateral ventricles. Then through the interventricular foramina, the CSF enters the third ventricle, this here third ventricle, and then through cerebral aqueduct or sylvius, the fluid is going to enter the fourth ventricle. And from here, through the lateral and median apertures, it is drained into the subarachnoid space. And you can see over here, the circulation of CSF is then through subarachnoid space, and then it is going to be drained through the arachnoid villi of the dural venous sinuses into the venous blood. And from here, you can see then as it has entered the blood, then it goes into the rest of the circulation. So this is the pathway of flow of cerebrospinal fluid. Now, if there is going to be some disturbance or obstruction in the flow of CSF, it can cause a condition which is known as hydrocephalus. This is a congenital malformation due to the disturbance in the flow of CSF. Excessive accumulation of cerebrospinal fluid within the ventricular system can cause an abnormal enlargement of the head, and this may occur due to an increased production of CSF, which can be due to a tumor of the choroid plexuses, or there is some obstruction to the flow of CSF, also known as the non-communicating CSF. There might be different causes of this type of hydrocephalus. One of those causes might be congenital aqueductal stenosis, that is the narrowing of the aqueductal sylvius, or Arnold-Chiari malformation. Then the third cause might be a non-obstructive cause, which is the communicating hydrocephalus. This can occur due to the malfunction of the arachnoid villi, so the drainage of CSF that is not adequate. So in hydrocephalus, you can see that the head is going to be expanded. The head is enlarged, and over here you can see the ventricles, they are enlarged and expanded because of the excessive accumulation of CSF, and this in turn causes a bulging of the anterior fontanelle on the surface of the head of the baby. And you can see over here the cause in this particular case is the blocked aqueduct, so it's the obstructive type of hydrocephalus. And the typical procedure which is done to relieve this sort of obstruction is the insertion of a shunt, which is the ventriculoperitoneal shunt. And this is a surgical procedure done to shift the CSF from the ventricles towards the peritoneal cavity. So this is a baby. You can see the hydrocephalus, hydrocephalic child. The head might be expanded to up to 4 times the normal size. Now, what is Arnold-Chiari malformation? I mentioned before that it can cause hydrocephalus. This is the most common birth defect involving the cerebellum. There is a herniation of the part of the cerebellum into the foramen magnum, which leads to an obstructive type of hydrocephalus. And this is usually associated with spina bifida. Now here we can see the comparison. This is the normal cerebellum, and you can see over here that if there is a herniation of the cerebellum into the foramen magnum, then this can cause the obstruction of the CSF flow, and that in turn can cause hydrocephalus. Another brain defect that you should be familiar with is schizencephaly. This is a rare disorder in which large clefts will occur in the cerebral hemispheres, sometimes causing loss of brain tissue. So this is an axial CT scan of a 6-year-old child, and you can see over here the clefts in the brain tissue. This condition is known as schizencephaly. Now that we have covered the basics of the neurodevelopment, I'm going to summarize at the end and a little recap of the previous discussion with the help of a few multiple choice questions. So since this has been a series of lectures on development of the nervous system, we're going to start from the beginning. So here is a scenario that a pregnant lady at the ultrasonology clinic during her routine checkup was informed about the anencephalic fetus. Now, what's the most common cause of anencephaly? Now, in this MCQ, anencephaly is the condition in which there is the absence of the brain tissue, and the most common cause of that is non-closure of the cranial neuropore. So if you recall the early stages of neural tube formation, there is going to be a closure of the neural tube, and this closure occurs in a craniocaudal sequence, and the cranial neuropore is going to close before the caudal neuropore. If the cranial neuropore fails to close, then it is going to lead to the congenital malformation, which is known as the anencephaly, in which the brain tissue is going to be absent. So this is the answer to this MCQ. Now the next one, the multipolar neurons in gray matter of spinal cord are derived from. Well, these are neurons, so they are going to be derived from the blast cells, which are known as the neuroblasts specifically. Prenatal ultrasound reveals an infant with an enlarged head and expansion of both lateral ventricles. This condition is known as, we just talked about this condition in this discussion, and you know that is hydrocephalus, in which there is an enlarged head due to expansion of both lateral ventricles. So B is the answer for this MCQ. Now the next one is lamina terminalis is the thin sheet of brain tissue that stretches upward from the optic chiasma to the rostrum of corpus callosum. This lamina terminalis is derived from, then again we talked about it in this discussion, that is telencephalon. Telencephalon is the part of the forebrain that forms cerebral hemispheres and the lamina terminalis. So D is the answer for this MCQ. Commissure is the bundle of nerve fibers that cross the midline and connect the right and left halves of the cerebral hemispheres. Which commissure is the first to appear embryologically? Well, the first one that is going to appear is the anterior commissure. A is the answer for this MCQ. So keep that keep that in your mind, that this is the first one is the anterior commissure. Now the next MCQ, which of the following cells of nervous system are derived from neural crest cells? Neural crest cells are going to form dorsal root ganglion. Okay, so B is the answer for this question. You should be familiar by that by now. We repeatedly talk about the different tissues which are formed by the neural crest cells. Dorsal root ganglion are derived from neural crest cells. So this concludes with today's discussion, which was the last topic in the neurodevelopmental series. And you can also do the recap of these lectures, which are the 3 series covering the neuroembryology. And if you found today's discussion helpful, then don't forget to like and subscribe to my YouTube channel, AnatomyMentor. And you can do that by just clicking on the picture that is going to appear at the end of this video. And also don't forget to hit the bell icon for any recent uploads and updates of my different presentations. And enjoy your studies. Take care. Goodbye.